and good morning to you all. Yes, we are living in a moment where negotiation and conflict resolution have almost become like dreams or impossible things. We are witnessing very hard times, and it's difficult to talk about negotiation when conflicts are really taking a shape much more geared to war and to the law of the strongest. Dr. Ramos-Horta has an experience of trying to negotiate and being very successful in that, especially lately in Africa, in Guinea-Bissau, as a special representative of the UN Secretary General and head of the UN Integrated Peacebuilding Mission in Guinea-Bissau. He was able to find a peaceful solution to a very difficult situation in a conflict involving the military, sides of the military and the civilians in Guinea-Bissau between 2013 and June 2014. So why don't we start with you, Dr. Ramos-Horta, telling us about this experience and how you reached success.
Thank you. I ended my time in office as president in May 2012, and I was due to begin active work as vice president of the newly created Asia Peace and Reconciliation Council, which comprised leaders from Asia, former heads of state, prime ministers, foreign ministers. Top on our agenda were Myanmar, Rohingya situation, as well as South China Sea. And then I was asked by the Secretary General to serve with the UN in Guinea-Bissau. Why someone from the Far East, remote from the African continent, would serve with the UN in Guinea-Bissau? Well, partly we have a common history. My country's personal relationship with PAIGC, going back to Amilcar Cabral. I had been to Guinea-Bissau before when I was foreign minister of my country. I was sent there by the CPLP, Comunidade dos Países de Língua Portuguesa, to try to talk military there and others out of a planned coup there. So I was familiar. And I accepted. Consulting with the new president of my country, the prime minister, whether I should accept. They said, yes, go. We will be behind you. It's a way of giving back to the United Nations, which helped us a lot. Our own independence, nation building, state building, is a way to give back to the Portuguese-speaking country community, but particularly to Guinea-Bissau. So I went there on a very broad mandate by the Security Council. I could commit myself only to 1 year. I'm not at the age where you can have a, indefinite. So I set 1 year. And then when I was asked by people in my own country, what can you do in 1 year? I said, if in 1 year I can at least create an atmosphere of less fear, a habit of dialogue, less suspicion of getting people to talk, I would consider that already a major contribution. Arriving in the country, Guinea-Bissau, I faced a situation where people lost hope, faith, after 40 years of successive coups, failures of government. Mm-hmm. And on top of it, the international community. But when you talk about the international community, you're referring to some in the international community, because often we invoke international community, ignoring that some in the international community don't agree with that particular position. For instance, the slogan is that the international community decided to impose sanctions on Guinea-Bissau. But which international community? ECOWAS, the countries of the region, did not impose sanctions. African Union did, because automatically there's a coup, sanctions are effected. The European Union did. But I, as an individual sent by the Secretary General, had to work with all in this situation. But within ECOWAS, there was no agreement either. Between ECOWAS and African Union, there was very serious differences stemming from other reasons, not necessarily because of Guinea-Bissau.
And that's because of the ambiguous nature of the coup itself. If you could explain,
yes.
What was the coup?
Yeah, the coup took place because the then Prime Minister of Guinea-Bissau, Mr. Carlos Gomes Jr., who never had good relationship with ECOWAS countries, with Senegal or Nigeria. He was more into relationship with Portugal, with Angola, to help the country reforming the armed forces. He signed an agreement with Angola, and Angola brought in a number of troops, equipment. And when you don't have a dialogue within the country, when you don't have dialogue between the country and your neighbors, suspicions that might be mere suspicion become facts. So each side starts taking preemptive measures, and the military thought that the president of Angola there were to undermine the role of the military there. So complicity between Carlos Gomes Jr. and Angola. That was not the intention, obviously, of Angola, but that was the perception, and no one's talking to anyone. So the coup happened, and another setback for Guinea-Bissau. And so I was asked by Secretary General, go and, if you read the Security Council resolution, it's a very, very tall order. And then you have the issue of a alleged drug cartel, drug trafficking. Guinea-Bissau was called a narco state, the first narco state in the world. But upon arriving there, I started researching, reading, traveling around the country. I didn't see any real signs of illicit wealth, which you see. You don't need to be an Einstein to figure out whether this is true. We know drug trafficking happened throughout West Africa as it happened elsewhere in the world. But I thought that the powers that be were picking only on a small, defenseless country, Guinea-Bissau, when drug trafficking is all over West Africa, but it has its origins in Latin America, and no one had the courage to say, sorry, the origins of the problems are in Colombia, in Bolivia, in Peru, partly in Brazil, because mules, how they call it, mules, they leave the airport of Sao Paulo very comfortably. No one bothers them with drugs inside their stomach, intestines. Transit through the airport of Lisbon. No one bothers them because they're in transit, and they discharge it in Bissau. And I say, I'm sorry, but there are two poles of this problem. One is in South America, because there where they produce. Africans don't produce drugs. And the other pole is in Europe, because the Europeans like too much the drugs. And the Africans have always historically become victims. And they do not produce drugs, they do not consume drugs. The problem has its origin in Latin America and in Europe. So I had to address all of this. I refused to sign reports calling Guinea-Bissau narco state. And I draw their attention, the United Nations attention, and people were not very happy, to bigger issues than drug trafficking for Guinea-Bissau, and that is illegal fishing and timber logging, destruction of the forest, Guinea-Bissau and West Africa. I was even told, don't put this in the report to the Security Council. Some countries will be upset. At least I don't care. These are the facts, these are on the ground. I'm not going to be in collusion with this ripping off of a country.
And did you find actors ready to negotiate there when you got there?
Well, I gained, because of my personal history, people trusted me. I was able to talk to the military political leaders as brothers. I would tell them, eu chamo-vos irmão. I would tell the former President Kumbayala, he passed away, Excellency, can I call you brother? He said yes, and you know why? If I treat you as president, I cannot say certain things out of respect. But as brother, I'll be frank. So can I call you brother? He said yes. And so you have to gain confidence of people that really feel that you really care about them. You care about the people, the common people. You care about the state of the affairs of the country. Gaining confidence, then you work with them. What are the alternatives? What are the solutions? And not easy. You know, at some points, myself, I thought myself, why I end up here? I'm already 64. But you cannot just give up. You know, the way people trust you. Well, and then I have the advantage of my country. Most of you don't know, it's independent only 12 years ago, but by act of God, as we became independent, we start also generating oil and gas revenues. So we have a liquidity. If it were not for my own country standing behind me, putting in money for the elections, so Timor-Leste with Nigeria, the two countries that spend most money on the electoral process in Guinea-Bissau. My country contributed with up to $8 million in cash and equipment and personnel. Nigeria about $8 million, 3 million euros from the European Union, and then small amounts from different countries. UK, 250,000 euros, et cetera, et cetera.
But how do you get people to yield power? Because that's what it is about. Yeah.
Yes, but first you have to create the dialogue, the conditions in the country for people to talk. And I spent endless hours, morning, afternoon, evening, in my home, one-on-one, or 2 or 3 leaders. I would go to their homes, we'll talk, and up to midnight, 1 in the morning. But also, I was fortunate in that I had strong backing from Washington. I consulted with the United States administration, those who really care about Timor-Leste, about Guinea-Bissau. When I first went to Washington, April 2013, all they wanted to hear about was drug issues. I met with many people in DEA, and I met with an Assistant Secretary of State. I think she was here yesterday in her previous job. She was very well informed, very sympathetic. But other than that, I went to Congress to visit old friends from my years as Timor President, Foreign Minister. They said, one senator said, Jose, what the hell are you doing in Guinea-Bissau for? And I had to explain the situation. Well, but slowly I got U.S. strong backing, and whether we like it or not, you know, U.S. remains an indispensable partner for Guinea-Bissau, for I presume anywhere in Africa. Second, the European Union. But the European Union was far more complicated because of the political decisions. You know, in Brussels, there was a coup, and under the various agreements, there is a coup, automatically sanctions are imposed. And at the same time as I was making efforts to have a transition inclusive government, and we succeeded. The most inclusive government ever in the history of Guinea-Bissau.
Yeah, we had elections this year.
And then we had elections. But even with that inclusive government, the European Union still refused to gradually lifting sanctions. I have to say, frankly, I was a bit disappointed, and we all know consistency is not a virtue in international relations. There were coups and coups. There was a coup in Mali, but because of French strong presence there, no sanctions on Mali. a coup in Egypt, but because Egypt is far too important, no sanctions on Egypt. A coup in Thailand recently. Thailand is too important, so no sanctions on Thailand. A coup in Guinea-Bissau, well, let's impose sanctions on these small, poor kids. And I'm not saying that in terms of criticism, but more of cynicism.
Okay.
And the reality is, in the end, whether in Guinea-Bissau, whether in Mali, whether in my country, in Afghanistan, choices have to be made by the people on the ground, leaders, civil society leaders, military.
Okay.
No amount of international pressure or help can succeed if we do not succeed in talking to the leaders there to get their act together. And I have to say, I left the country in June, the mission ended, elections were held, the new government took office. Thousands of people were in the streets thanking me, the military also, and said, but this is just part one. Part two is after the elections, the rebuilding of the country, of the state institutions, the economy. And that's where I have doubts that when the pledging conference takes place in February next year in Bissau,
okay.
The same countries that are able to find billions of dollars to rescue auto industries, insurance companies, the same countries that are able to find billions of dollars to rescue Greece, Portugal, Ireland, are going to find few miserable dollars to help Guinea-Bissau.
All right, let's open this for a few questions and see what we get from the audience. Sir, please. First.
Thank you very much. My name is Adam Agaye. I'm from Senegal, neighboring country of Guinea-Bissau. I thank you very much for your efforts and your country's efforts in helping out that miserable country. From what I heard in your presentation, it seems that the problem in the country is to a large extent an in-house made problem, lack of dialogue within the country. That's not the point I wanted to make. The point I wanted to make here has to do with the broader picture of this conference. I don't know if the organizers of this conference are here or not, but there is a serious problem when you talk of Atlantic dialogues. You cannot be doing dialogues involving Atlantic dialogue without having stakeholders from sub-Saharan Africa sitting there talking about their issues. And when you look at the pictures here of the list of people who are talking, you hardly will find either a moderator or substantive speakers from sub-Saharan Africa. If we have to have a dialogue, we need also to be on the driving seat and bring about the issues. Tonight, there will be a discussion about geopolitics of Africa. Last night, there was a discussion about funding of development of Africa and so on and so forth issues. Hardly will you find Africans sitting here. This must be addressed if I believe this dialogue is truly to be an Atlantic dialogue. That's the first question I wanted to make. So it's unfortunate I'm raising it in your presence based on you. Second question I wanted to make is the unfortunate thing that I've seen yesterday, the fact that you bring the old guys who have done their bit when they were running offices. They were people who managed in their countries to allow constitutional reform not to go, trying to short-circuit constitutional reform in their country in order to stay in power, coming back here and lecturing about the African Union being the regional powers that should fix Africa's problem when we know that Africa at this stage, against this rising side story of Africa, is still facing very tough problem with emergent stock, with people taking our resources. These issues are not brought back to the fore in the discussion. I would want to hear this more and more, and this is addressed to the organizers of this conference, not to you. Thank you.
Okay, thanks very much. Do you have other questions? Okay, here. Please.
Yes, Simon Pinto from...
Take the mic, please.
Simon Pinto from Portugal. Let me congratulate you, Mr. Ramos-Horta, because I think you have done quite a job. It was, I know, relatively well the situation there, and I think you were very successful because finally the military also have gone, and apparently we are going to have a What I would like to hear from you is, don't you think that it was extremely important also the trust that was possible to create between CPLP and ECOWAS? Because that, I thought, was one of the serious problems, was when the Angolans went there without giving some, well, I'd say some saying something to the Nigerians before. I think that was what raised the mistrust there and what pushed also the people from the military to make the coup against Mr. Carlos Gomes. Thank you.
Thank you. Any other question? Here. Here. The gentleman. Okay, then you. Okay, no problem.
Good morning. Thank you for your explanation, Mr. President. I'd like to point two things.
Can you just say who you are? Where you
Okay,
are
I'm Bosco Monte from Brazil, Brazil Africa Institute. I'd like to ask us two things. First, do you think the private sector could contribute with the peacemaker discussion and also to the improvement of the development of the country like Guinea-Bissau, and also how the universities around those countries, from the CBLP countries, for example, Brazil, Portugal, could help to implement some projects in those countries?
Okay, thanks. And then the gentleman beside here, and then you.
First, Marcos Freitas from Brazil. Mr. Horta, what a pleasure it is to see you, someone I have always admired for the work you have done in your contribution to the world. My question is this. You worked there in Guinea, and you had an important role in setting up the whole thing. What are some of the personal traits that you think a mediator in a situation like that should have? You know, we have the story of the Beagle Channel and Cardinal Samurai, who played an important role there. What are some of the traits that anyone in the future, when the world is realigning and new negotiators will be asked, what are some of the traits that you think a person should have to carry such an important role?
Okay.
Thank you.
And then the final question, the lady there.
Good morning. My name is Ndidi Muneli. I'm a social entrepreneur based in Nigeria. Thank you for your comments. I was curious about the role of oppositions in governments and whether you can talk a bit about how in Guinea-Bissau, and then we can translate it to other parts of the world, how you can nurture a strong opposition government so that they can hold the current administration accountable to deliver, and you can have some type of upset. I mean, we see it in the United States with the Republican and the Democrats, and it can be a force for positive change or negative, but I think in countries as small as Guinea-Bissau and many other countries, you see that the dominant party is so strong and the opposition is inexistent, and that kind of fosters a lot of impunity. So beyond your work, what can we do to nurture that type of opposition movement? Thank you.
So we have here the constitutional reforms which are made to stay in power rather than to yield power. The relation between the Portuguese-speaking country community and West African organization, what the private sector could do, especially from Portugal and Brazil for Guinea-Bissau, and personal traits that a moderator should have, and the role of opposition.
First, I would like to emphasize how important, critical, besides obviously the people in the country, the leaders, all sectors. I met with everyone, from the military to political leaders, but also to the imams. Guinea-Bissau has a majority Muslim, very small Catholic and Protestant, plus the chefs de tabancas, the community leaders. They are fantastic. These are the people who really hold the country together, the church leaders, the imams, and the community leaders. But then with the regional countries, critical to the fate of Guinea-Bissau is Senegal, Guinea, Gambia, and beyond, Nigeria. And I travel across all over West Africa and develop exceptionally good working relationship with President Goodluck Jonathan. of Nigeria, as with President Macky Sall of Senegal, with President Ouattara of Côte d'Ivoire, at that time in his capacity as President of ECOWAS. And that was the instructions I got from the Secretary General. Always give precedence to the sub-regional organization, ECOWAS. And I have to say, if it were not for their partnership with me and me with them, regardless of all the goodwill in Guinea-Bissau, we would not have been able to achieve what we achieved. And I was often critical of the European Union and others, was precisely because everybody imposed sanctions and then led it to ECOWAS with their own problems already in the region, particularly in Mali, dealing with the financial burden of keeping Guinea-Bissau afloat. It was primarily Senegal and Nigeria that pumped money to Guinea-Bissau for the 2 years of that period to keep the country, prevent the country from getting worse than it was. So the role of the ECOWAS was critical in this regard. But so was CPLP, particularly Brazil, Portugal, Angola, and so on, that in the end, we managed to bring everybody together, ECOWAS and CPLP. I met with President Macky Sall in more than one occasion, and he kept insisting on the importance of the role of CPLP in Guinea-Bissau. Because regardless of anything, Guinea-Bissau cannot change its borders. It has to know how to manage relations with its neighbors. And that's what I kept telling my brothers in Guinea-Bissau. I told them, we have 2 neighbors in my own country, Timor-Leste. One is Australia, the other one is Indonesia. And can you imagine how different these 2 countries are? And we have a great relationship with them, with both Indonesia and Australia. We have a great relationship with a not so clear close neighbor, but is a neighbor, China. And we have a close relationship with another country, neighbor to everybody, and that's the United States. Neighbor to everybody because it's a global power. And so I told my brother. Then on the question that our sister from Nigeria raised, from day one, I told my brothers in Guinea-Bissau, please abandon the past practice in your country, same like we have in my country, of winner takes all. Because in other well-established democracies and well-established democracies, you leave office, you find other sources of privileges of revenue. In our countries, being a minister, being an MP, you have influence, you have economic, financial privileges. Well, it was not easy. But what I can say is that the other day, a few weeks ago, I was in New York to attend some meetings. The Prime Minister of Guinea-Bissau, Domingos Simões Pereira, was there. And who he brought along with him to the UN General Assembly? The main leader of the opposition, the PRS, Partido Renovação Social, which a year ago, with PAGC, was really at war, which a year ago everybody was saying the big problem of Guinea-Bissau is the relationship PAGC and PRS. So something they listened to. And the Prime Minister, Domingos Simões Pereira, is a diplomat. He's very, very experienced, conciliatory. So I believe he's able to he has been able to bring everybody together. And the military have accepted the result of the election and even accepted the change of leadership. I told at the time also, you have 3 months after the elections to carry out a reshuffle of the army leadership. Nowadays, even in the Vatican, even the Pope changes before he dies. In the past, the Pope is there until he dies. Now they even change that. So let alone here in Guinea-Bissau. So, and without any commotion, the General Antonio Njai, the coup maker 2012, was changed. But I always told them, please always change through dialogue, finding honorable, dignified, safe exit for them. And then we have the problem. When you're dealing with this, you have a problem with, for instance, the United States. The United States has indictment on General Antonio Njai.
Unfortunately, our time is, well, we can talk about this later in the coffee break and all that. Thank you so much for taking part. And please join me in a thank you for Dr. José Ramos-Horta.
Ladies and gentlemen, please welcome Mr. Nick Gowing from BBC World TV.
Good morning, everybody. And this is going to be a sobering, slightly scary session, but something which needs to focus us all on what is happening in public health in Africa. I'd like you to use, please, your spot me to help me guide the discussion. And I'm talking while the chairs are changed because we have three very leading experts on health in Africa, one of whom has just arrived at 3 o'clock this morning from being at a Vatican conference where he submitted something directly to the Pope. But we are talking now about Ebola, but it's also what the spread of the deadly disease highlights about the state of healthcare in Africa, especially after years of battling so many other issues, particularly HIV/AIDS and also cholera and malaria. How did early warning fail on this? And what signals does this now send for the state of healthcare right around Africa, individual sovereign states? Let me just bring you up to date with the latest figures. 10,000 reported cases, almost 5,000 deaths, and much has yet to be discovered. Guinea, Sierra Leone, and Liberia are being racked by Ebola with no good signs. Nigeria officially is clear, Senegal too. Now Mali overnight has confirmed its first case, and it's a 2-year-old girl who traveled hundreds of kilometers by bus from Guinea, showing, quote, signs of the disease, quote, many people were exposed. And in New York City, you have the challenge of Dr. Craig Spencer, who was working for MSF in Guinea, diagnosed, and now the governors of New York and New Jersey have officially mandated a 21-day quarantine for doctors who have come back, or health workers who've come back from West Africa. Many questions then about how, quote, this deadly and dreaded Ebola virus got ahead of us, how we must catch up on the most urgent and pragmatic way possible. That came from the Director General of the World Health Organization, Margaret Chan herself, back in September. In other words, how has this happened? What are the lessons now for health right across Africa? Many questions still to be asked. How did it get ahead of us, to use the World Health Organization language? What went wrong with WHO analysis, the medical analysis as well, the diagnosis, the projections? A failure to consider the worst case might be possible and therefore was likely. Why underreporting, especially of new cases which have gone missing? And MSF, let me remind you of what MSF warned about on the 31st of March. Quote, an epidemic of a magnitude never before seen, and especially because of the distribution of cases. Yet the next day, the World Health Organization said that this was scaremongering. We need to be careful with an outbreak of sporadic cases. There are positive signs. Some of you will have seen the wonderful picture of Nina Pham, one of 2 nurses who was infected dealing with Thomas Duncan, who died in Dallas. There she was, embracing President Obama at the White House. So there are positives here, including a British health worker who got Ebola, was taken back to Britain, and is now back helping fight the disease where he'd been working. The World Bank president, Dr. Jim Kim, a medical doctor and a leader of public health analysis before he joined the World Bank, has warned that rich countries must stop Ebola where it starts. But as he says, there's a big shortage of health workers, and this is what's going to come through from our discussion. Why is there such an emergency at the moment? Nearly everyone involved in the response failed to see some fairly plain writing on the wall. That comes from a leaked email inside the World Health Organization, which has not been confirmed officially. No one saw the writing on the wall or understood what it meant. So these are the implications, particularly for the demographics of Africa, the 20 to 40-year-olds, the new hope for Africa, those who can bring new economic prosperity, new wealth, who may be afflicted if Ebola is not stopped in its tracks effectively in the next few weeks, perhaps. So there are many, many issues to discuss in the next hour, and we hope to be joined from Liberia as well shortly. But let me ask, and thank you for coming in with my back turned to you, but the chairs were moved, and I wanted to at least make clear where we were trying to get to by about 10 past 11. Let me first of all ask you, each of you, to introduce why you are here and also the kind of experience you've got. Debbie, first of all.
So I'm Debbie Birx. I represent the U.S. State Department and am privileged to work on PEPFAR, which was the largest single American investment or global investment in HIV/AIDS, the pandemic that we also have raging on the continent that is also deadly, incurable, and really has been working on health systems to respond to the HIV/AIDS pandemic, which are also very applicable to controlling Ebola.
Are you optimistic?
Very optimistic.
Good. Optimism right at the beginning. Professor Paul Farmer, he arrived at 3 o'clock this morning via Casablanca from Rome, having been at this meeting involving the Vatican. And Paul has just written in the New York Review of Books, the Ebola virus is terrifying because it infects most of those who care for the afflicted and kills most of those who fall ill. At least that is the received wisdom. Paul, what is your work?
I'm a professor of medicine, infectious disease doctor and anthropologist at Harvard University, and co-founder with Jim Kim, who you just mentioned, among others, of Partners in Health, which works to deliver health care and to train local partners to respond to health emergencies, both the acute ones, like Ebola, and the more chronic ones that Deb mentioned.
Raj Panjabi, you were born in Liberia. You live in the States at the moment. You're a doctor, you're a physician. You've done an enormous amount of work there. What is your background in healthcare in Africa?
Well, I'll say I'm proudly born in Liberia. Thank you for that. I've been working as the CEO, co-founder of Last Mile Health. Last mile meaning remote areas. We are bringing healthcare through village health workers into the rainforests of West Africa, focusing in my home country. Same rainforests, by the way, where this epidemic started, of course, in a different country in southern Guinea.
Right. I hope we're going to be able to go to Liberia shortly. Let me now drill down a little more into your experience. Debbie, what is your feeling about the way things are now moving and have gone, particularly on Ebola, but what it indicates based on your enormous experience with AIDS and HIV across Africa?
Well, I think it indicated the fragility of the health system in West Africa. And in general, these countries have not had the significant investment that we've been able to bring to many of the other countries in sub-Saharan Africa in partnerships with ministries of health and civil society. And it really shines a very bright light on the difference between the control of Marburg, which is another hemorrhagic disease, and Ebola, in the DRC and in Uganda, where there's been repetitive outbreaks over the last several decades, immediately controlled, because the community believes they have access to the health care at the health center. And they believe that in trust that their government will have the necessary resources, the human capacity, the infrastructure, the medication that is needed at the health center level when they go to the health center. I think you'll see in Liberia and Sierra Leone, in many of the health centers, they didn't have that same relationship between the health center and the health system and the community that it serves.
Right, again, we're going to drill down. We're going to go to Liberia in a moment. Paul, you've just been in Liberia, and you hope to go back, but you've described it as an acute and brutal affliction. Why is this still happening after so many years of trying to focus on public health across Africa?
Well, I don't think, as Deb said, I don't think there has been that much focus on public health after the wars in Liberia and Sierra Leone. And so the system's very weak. We don't have the staff, the stuff, the space, the safe space to manage a highly contagious illness And then finally, we don't have the system. So happily, we share optimism because each of those 4 categories, staff, space, and systems, can be put in place and will.
Now, Raj, Forbes described you as the healthcare model for 1 billion people with last mile health. But what's the reality in your country, which we're going to go to in a moment, in Liberia, when it comes to the numbers of health workers?
It's abysmal. It's abysmal. I fled during the war as a child in 1990, went back 15 years later after the war ended, and we had just 51 physicians for a country of 4 million people. That would be the equivalent of New York City having 8. Imagine having 8 physicians trying to deal with an Ebola crisis, much less any other crisis, from malaria, from the complications of childbirth. So there has been some progress that's been made, thankful to the government of Liberia and its partners over the last decade, but there hasn't been enough progress made in the most rural parts of the country. And right now what's needed is really a Marshall Plan for Ebola recovery. Hundreds more doctors, thousands more nurses, tens of thousands more community health workers. And that's not a difficult thing to achieve if we have enough focus and attention.
Is it about money or skills?
The skills are there. There's enough. There are enough opportunities. We train local village health workers who have a 6th grade education, and they are able to become medical providers within weeks. There are doctors, physician assistants who are stepping up to serve in Ebola treatment units from the woodworks. What's missing is the financing in these countries.
All right. Let's try and go to Monrovia now, to Kris Torgeson, who's from Médecins Sans Frontières, where you were, and you were with her, I think, a few days ago, Paul. Kris, can you hear me? Good morning. Yeah, you're facing an audience of about 200 here in Marrakesh. I have in front of me the World Health Organization bulletin from 3 days ago, talking about still an enormous gap between need and capability. What's your assessment today, this Saturday morning?
Well, I wish I could be sort of bold as to make an assessment of where we are with this outbreak. I think what we have to remember always is that this is an outbreak of unprecedented scale and unpredictability, and that many of the predictions, whether high or low, are really based on information that unfortunately we cannot fully count on. And I think what's most important is to know that the epidemic can have peaks and it can have lows, and until we really break the chain of transmission down at the very community level in all 3 countries in the region, we will not be seeing the end of this outbreak. And so there is really much more to be done. Here in Liberia, we've had some good news in the past weeks, in the sense that we've seen the numbers of cases coming into the Ebola treatment centers lowering. We've been trying to understand that better, and know that there are some people who are afraid to come to treatment centers, who are still treating people at home. There are still unsteady. There is a potential of some reduction in the caseload, but we do not think that that is any sign that we should be dropping our vigilance and slowing in any way the response, which is still not up to the speed and the level it needs to be.
Kris, can I ask you a couple of practical questions? When it comes to investment in medical facilities to isolate people who are suspected of having the condition, and secondly, what came out in this World Health Organization bulletin of just 3 days ago, in Liberia, a continuing failure to even integrate laboratory results into clinical epidemiology reports. In other words, to even understand what the evidence is.
Yeah, I think that's a really important point, that data gathering and putting together a real-time picture of where the outbreak is happening and what's happening in hotspots around the country and the region is really not there yet. As your panelists have said, in Liberia, the healthcare infrastructure, the epidemiological tracking structure, et cetera, has been very weak. I was here in 2003 during the height of the war, and I had hoped to come back and see a lot of progress made on the healthcare infrastructure. There is some, But it's very, very sad to see that Ebola is again taking a great toll on that infrastructure, and which was weak in the first place, and then is only making it weaker. And so I don't think we do have a full sense of where the outbreak is, and certainly not able to break the transmission at the very community levels that we need to.
And Kris, very quickly, if you can, what challenge is there to your capacity in MSF? You're advertising widely for money at the moment, but when it comes to you getting resources on the ground to at least help push that effort forward, quickly if you can.
Well, I think it's not about us. I mean, we are doing everything we can. Of course, you know, we're responding to crises elsewhere in the world. This has been also an unprecedented effort on the part of MSF in the region. You know, we have just in the 3 countries, we have 270 international staff and 3,000 local. But I think the real issue is the slowness of the international community's response. There have been many commitments. We have started to see people and others coming in, but we are seeing still a slow focus on structures and commitments versus seeing some real activities on the ground in the areas where they're most needed. And I'm speaking here not just in the capital of Monrovia, but elsewhere in the counties where we're still seeing cases coming and we don't know what's happening. So I think there's a big challenge for an organization like us. We know there's challenges for international organizations, but we still think more can be done and faster. And the biggest pressure, without doubt, we have to say again and again, is on the Liberian and the health care workers and non-health care workers who have been responding to this outbreak very bravely throughout the country with very little to help them. And it's just taken a massive toll. It's very saddening and will be hard to recover from quickly.
All right, Kris. Well, thank you very much indeed for joining us. We hope we might be joined later by someone from the government, the Minister of Information. Let's now drill down into some of those issues about capacity. We know the problems of the past few weeks and past few months of lack of early warning and so on, and lack of mobilization. Your reflections now on the very clear messages that are coming through. Debbie, based on your work for HIV in particular.
Well, I think we're all going to have to step back from this for a minute just to really understand the fragility of the systems that we're talking about and the fact that there hasn't been real advancement since the wars and what it really takes to create a system that's responsive. Because although we're talking about Ebola, we're not talking about the number of women who no longer have access to the health clinics that have difficult births and are now dying in childbirth in these very same countries. The individuals who have malaria, TB, or HIV that no longer have access to the health clinics. So this is a crisis of Ebola, but it's a crisis of all of the diseases in these particular countries and not having a comprehensive response. Yet we do know, and we have great illustrations of what happens when the international community and through great actors like Paul Farmer and others that come in and work day after day, side by side with their colleagues, to work on building the human capacity and the infrastructure needed for the response, which we've seen in country after country through PEPFAR funding. Having that consistency of funding, that consistency of people on the ground, that dedication of person to person. I mean, these capacities built people by people. We often focus on the money, but it takes people to do this work. And it takes, we heard that there's incredibly dedicated Liberians, and we need to stand beside them and help them support them through this.
Is there a level of predictability, Paul, when you look at what is happening, and you've been there recently, when you say, and I quoted this at the beginning, at least that's the received wisdom, is there still doubt about what Ebola is and how to control it and contain it?
Well, I don't think there's doubt about what Ebola is. You know, it's a disease that jumped from animals to humans, but that's true of HIV, and in fact, in the same region. I think the doubt that I was trying to insert, and after having heard from Kris and Debbie about other key messages, the one that I would underline in front of all of you is that we have to do better at taking care of people who are sick with Ebola. Because there's no reason, at least there's no reason that I can see, or we can see, that you should have 90% mortality. And to lose your healthcare workforce because they don't have the staff and space to take care of critically ill people is a great tragedy that's going to take a long time to recover from. But that's also the reason that people are afraid to go into a healthcare center. It's because they don't, if they know, and people do know, that they can't get good care, that compounds the fear and stigma, and which have had very adverse effects, as you know already, on the region economically. So we've got to improve the quality of care inside Ebola treatment units, and as Deb said, for people who don't have Ebola, poor quality care is related to difficulties in infection control and related to stigma and fear.
You've called this terrorism of poverty. Why do you say that?
Well, I mean, I think that the grotesque lack of any kind of social safety net, meaning you're sick, you're on your own, you get hit by a car, you're on your own, you have obstructed labor, that is, you're pregnant and you start to bleed, you're on your own. That's a terrible thing, and it's frightening, and it's violent to those who experience it. Often middle-class professionals, healthcare professionals can avoid it, but as you see here, there's no one to come in and save them either. So that's what I meant by terrorism of poverty. And it's not that it's only affecting people who are poor. It mostly affects people living in poverty, but it can affect all of us. We need safety nets.
Let me pick up on what Kris said from Monrovia. Let me just pick up on the fact that she said not enough has been done. Everyone's been too slow. The US has now committed a significant amount. You're working on the President's task force here. But it's not enough. It's not fast enough. And just the basics of how you build these new, very crude clinical centers to at least help control. What are the practical issues of controlling this, Debbie, at the moment?
Well, I think it's the relationship of the health system with the community. So currently, President Obama and the administration and Secretary Kerry have brought all the resources to bear. We've got the military in there building facilities. We have CDC sending in healthcare workers. We have mobilized all of our PEPFAR individuals that are already on the continent.
Do you want to explain what that is?
So those are it's the President's
PEPFAR,
emergency plan for AIDS relief. And it's a multi-billion-dollar commitment year after year, which I was struck by the last panel talking about winner take all. This is really an extraordinary program because although it was started by a Republican, President Bush, it was expanded, built on, and brought to a new level by President Obama. So I think that kind of continuity is where you get success. And so you can't have these programs that stop and start and you don't get really successful integration. So I think PEPFAR is sending, the President's Emergency Plan for AIDS Relief, is sending its personnel from all of the different countries to go to Liberia to work on this issue. They went to Nigeria to work on tracking and tracing. What does that mean? So there was an Ebola patient in Lagos. For those of you who know Lagos will understand that's a little concerning. Large, fabulous, vibrant city. And immediately they were able to track and trace just under 3,000 individuals who were exposed. And stop immediately the next cycle. Stop immediately. So that's what we're talking about needs to happen in Liberia, but it really has that trust between the community and the individuals infected and the health system to be able to be presenting to the health system, get the care that they need, and stop the next cycle of infection. We know how to do it. We just need to do it together.
Well, given that we're examining the state of the healthcare system, and we have that case overnight of the 2-year-old girl who traveled hundreds of kilometers out of Guinea, quote, showing signs of the disease, quote, now many people are exposed. Both Paul and Debbie, what about the practical reality of how you track someone like that, a 2-year-old on a bus? Paul.
Well, as Raj said, and you really need a huge workforce, and there are people there in all the 3 countries, which, by the way, are probably at the very bottom of the heap in terms of public investment in public health after the war. So again, it's not mysterious. So you don't really have the tens of thousands of community health workers you would need, but there's a lot of enthusiasm of people wanting to be trained. They have to be...
Is it doable?
It's doable.
Okay.
It's absolutely doable. We just need to look at, you take the Lagos example, you had a couple hundred physicians, some hundreds of nurses, and thousands of people engaged in contact tracing. But again, if it's only a surveillance state or somehow perceived as punitive, it's very hard to do. It has to be an embracing healthcare system that can take care of people if they are in trouble. And that's what we need to do now. We should mobilize, if I say, let's mobilize 100,000 community health workers, train them, protect them, because they're not there to be, exposed either, and support them over the next few years. That means pay them. It would be a rounding error for some of the other programs that get done. We should invest in it. It shows we believe in investing in healthcare as a way to pull up the development of a country.
And does HIV give a precedent there, a useful precedent, a hopeful precedent, or not?
I think it does, because we realized with HIV, and again, we were late. All of us were late to the response on the continent. It was raging for more than a decade. Almost a third of women were already HIV infected before we had a global response where we all came together and said that this is unacceptable. And we've been able to not only save lives, but we're starting to actually turn the tide of the epidemic and get epidemiologic control. That means, just like with Ebola, you're stopping the pandemic in country by country. No one would have thought this was possible with HIV, but it's happening. And it's happening because the Global Fund, the President's Emergency Plan, all of the public and private sectors in Africa are working together. So we know what models work. It's translating that model to Ebola and working from the very bottom back up to rebuild what is needed to have a sustainable health system. And I say sustainable because that's a key piece of it.
Just before I go to Raj then, there's a principle here of trying to be preventative, but actually everything at the moment is reactive. How do you break that?
Well, one of the ways to do it is, as we've all said, is massive investment. We came to it late with HIV. It's probably unprecedented before that. And HIV is the first example where we made an investment that is adequate as opposed to inadequate. A second point is you really do need to integrate prevention and care. So it's not just avoiding simply being reactive and going to prevention, it's integrating prevention and care. There are already a lot of people ill. And, and I'm not just talking about with Ebola, with other afflictions that are readily treatable. And even Ebola, if it's just a rebuke to hope, if we say, well, there's nothing we do, we don't have a treatment, it's invariably fatal, that's A, wrong, and B, a disaster inside these places because it's not true. There is a lot that we can do to take care of people with Ebola, and it's the same, very similar to treating shock, meaning you need to replace the fluids that are being lost, and that is eminently feasible and in short order.
Let me now come to Raj, because we've heard, if you like, the experience there more broadly. You're chief executive and founder of Last Mile Health, and you've just explained that 60% of those in the rural area have no access to any healthcare at all. How do you translate what we've heard, the principle from Debbie and Paul, into the reality of a place like Liberia, where you could have easily many more cases like this 2-year-old who's turned up in Mali with it?
Well, I would say that this is, look, in a globalized world, Ebola anywhere is a threat to people everywhere. And that is true. We know it's true. And when you have a 2-year-old, you're talking about the 2-year-old girl that went to Mali, let's think about patient 0 in this outbreak. The 2-year-old toddler who was thought to come down with the infection in southern Guinea.
What do you mean by patient 0?
The first patient that was thought to be infected in essence where the epidemic started. Southern Guinea, remote village, hours away from the nearest clinic, no health worker in the village. A toddler comes down with a fever in the rainforest. A few weeks later, his mom dies. A few weeks later, his sisters die. A few weeks later, his village midwife dies. It isn't until 3 months before the healthcare system recognizes that a 2-year-old and his family and some people in his village have died, when finally someone ends up at a local hospital and the doctor dies of the same symptoms. Why aren't we sounding the alarm about that when it happens immediately? That's the same thing that happens with malaria. I was when a medical student a decade ago, 10 kilometers from where this village is in northern Liberia. I was holding kids that were 7 days old. The mother was sick when the child was born in her village 8 hours away, but she had to walk 8 hours to get health care. This isn't the story just of Guinea, Liberia, Sierra Leone. It's 1 billion people on the planet who live in the world's most remote villages, and if we do not invest in putting community health workers in those villages, nurses in the clinics, doctors in the hospital, and giving them the training and the equipment they need, we will all suffer for it. And we're seeing that now. The cost of inaction is greater than the cost of actually solving the problem.
Because there are several questions here already about what accounts for the slowness of the response. Let's come back to that in a moment. One specific question, and please do post stuff on SpotMe. It really helps me understand what's on your mind, and I'll come to you as well a little later, but this gets into the mix much earlier. There's a question here about the potential ability of the locals and funding being an issue, as you said, Raj. Are they maximizing the local community outreach actors, especially in a place where most of the people are undereducated and live in those kind of densely populated areas and relate more to neighbors, national government? Is government doing all they can to facilitate community leaders and players, a kind of reporting system here?
I think the government's been watching and acting on this since March. At least in Liberia, that's the case. We work very closely with the National Ministry of Health and know they've been organizing meetings and actions since then. They haven't had the resources to get the job done. Our local actors, is there enough being done? I would say no, but I will say that local actors, health workers, all of us in this room, all of us watching ought to be extremely grateful, because this isn't about West Africa versus Ebola. This is humanity versus a virus that all of us are affected with. We know when local health workers, even people who are less educated, take a 25-year-old from the villages we work in named Zakba. When you educate her, even without a formal, when you give her medical training in a few weeks, convert her into a community health worker, make sure she's equipped, protected, paid, we can actually see complete reversals in the kind of disparities in healthcare we've seen. There was a remote rainforest district that we've worked in called Konobo with the Liberian government for the last 3 years. It's a rainforest community that looks no different than where this patient zero, the first patient in the outbreak, started in southern Guinea. There, the average age of death 3 years ago was equivalent to that during the plague in medieval Europe. 29 years was the average age of death for the population. In the last 3 years, we have, by employing local village health workers throughout the districts, like Zakba, local community health workers, been able to bring the immunization rates up to 97%, been able to bring the prenatal care rates up. This is possible. It's being done, and it's thanks to the kind of investments, governments like the US government have made around the world. We just need to see a lot more of it, and in the places that are the furthest reaches of the planet.
All right. Now, I think we can go to Monrovia to, is it the Deputy Health Minister, Elizabeth? Correct? Yeah, the Deputy Health Minister, Tolbert Nyenswah. Thank you very much indeed. We can see you. I hope you've heard some of the debate so far, but the real pressure on your government and your facilities, do you feel in any way that these many weeks into the crisis, you are beginning to at least control it, or not?
That's correct. We are beginning to control it. We are now far ahead of the disease. A week back, we were behind the disease, and the disease was progressing exponentially 4 weeks back. But now with the interventions that we've put in place to contain the Ebola virus disease, we've seen the interventions, like for instance, testing has done less than 24 hours, like about 600 tests are performed a day, and then we have more treatment beds as compared to 4 weeks ago, with about 725 beds that we can put Ebola patients, and so the number of patients we have in our treatment units are like 300 persons with about 300 beds that we are still doing active case search, active case finding, community mobilization to get people into treatment units.
But Minister, can I just intervene and ask, what kind of projection do you now have about the way epidemiologically this could go, the worst case scenario, In other words, do you have enough if the worst case comes to pass?
And this is why across the country, that's Ebola treatment units, are still being accelerated. We are still building more Ebola treatment units. From my epidemiological assessment yesterday, we are no longer having new cases of Ebola increasing. That is, as we were having more new cases popping up every day. This is not happening. The cases aren't going up. They are leveling up right now. And what we also see is that it doesn't mean that the disease has decreased, but then we have to make every effort to find every case in every community across the country. We also intensify our community mobilizations, active case search, active case finding. Also, safe barriers, interventions have improved. We have more than 53 barriers teams across the country, 16 of them in Moderator, which is the capital, the epicenter of the disease. Today, in the last 3 weeks, we haven't seen a case in one of our counties called Lourival. And so progress has been made, and we are resolved to intensify this progress and make sure we get the disease under control. Note that this is a regional disease, and so we are also concerned with what happened in Guinea, what happened in Sierra Leone, and our efforts should be holistic to deal with the situation.
One last question, if I may. This, of course, is a massive crisis for your country as you try to recover from years of conflict. You now have to think about how you plan for the future to create a more resilient health system, healthcare system. And we've just heard from Raj here that 60% of the rural population have no access to any healthcare whatsoever. Very quickly, don't give me the whole plan, but very quickly, how much do you believe you can now mobilize to create a resilient healthcare system to prevent this kind of thing happening again?
Basically, the plan right now is to deal with the Ebola virus disease and also look at the restoration of our healthcare system, because this is highly 14 years of civil war and was trying to rebuild our healthcare system. Mind you, Liberia was the fastest country to achieve MDG4 by the 1990 rate. Before 2013, we've already cut under-5 mortality by 5 because of the interventions, the immunizations, community health workers across the country, trying to train them, like the one Raj mentioned, the Kodomo example, that the last mile healthcare workers across the country, our maternal mortality ratio was improving, healthcare system was being rebuilt.
Minister, we're having difficulty hearing you. We're having difficulty hearing you, so I think we've got the message. So thank you very much indeed. Your sound is breaking up. Thank you very much indeed for making time to join us. And a wave here from Raj and also Professor Paul Farmer, even though maybe you can't see them. But thank you, Minister, or Deputy Minister, thank you. No one would want his job or the government's job at the moment. When you listen to the kind of things he's been saying, what else needs to go into the mix to make sure that this doesn't keep happening?
Well, I think what's really, Atlantic Dialogue should be really applauded for understanding that the foreign policy work needs to be part and parcel with health work in order for things to be successful. Yeah. But what normally happens, health is discussed over here among ourselves, and foreign policy and foreign ministers are talking about things among themselves. And that connection between economic growth, keeping young people healthy and thriving and having opportunities are all linked to having that safety net and health, knowing that your babies are going to be born and will thrive as children. So I think we all need to have, I love the map that you had in the back that show how we're all interconnected. We're interconnected over roads, we're interconnected over planes, we're interconnected in the internet, but we need to be interconnected as major communication groups, which doesn't normally happen. We rarely get to come and talk to foreign policy and entrepreneurs and others in the audience. We don't get to talk to you all. And yet you all are key to the policies that we need in order to have strong health systems around the globe and to have global health security that protects all of us and protects the most fragile countries and protects New York, London, Cape Town.
Because let me just say, there's an anonymous contribution here. The Liberian voice says we're in front of the disease from Monrovia. The international voices, you in other words, say we're in grave danger. There seems to be a disconnect with the messaging. What is the real situation?
I think the challenge, and we have hundreds of people on the ground and more to come, mainly local health workers. What Minister Nyenswah, who by the way all of us should also be applauding for being at the front lines of this, what he was talking about is week to week we're seeing in certain locales, areas in the country, the city of Monrovia for instance, the interventions that have been applied, rapid burials, getting people in for treatment, more treatment facilities going up. Those have actually started to become effective, it seems. In other parts of the country, we don't even know what the burden of disease is yet. And so, you know, the challenges in places where, you know, even the census at times is challenging to register appropriately without the right, without cell phone access. So 1 million people in Liberia don't have any cell phone access. We don't have access to roads. To get a basic registration, birth certificates for people, imagine those basic things are not being reported on properly. I think he's right to say, yes, interventions are being worked on, but we're still being vigilant because we know that the true burden of disease is underreported throughout the country. I mean, just so it's said, the CDC, the Centers for Disease Control in America, says that for every 4 reported cases, 6 go unreported. And so that's a huge challenge. And I bet that number is even worse in the rural parts of the country, of these 3 countries, which most of those countries are rural.
Let me ask you from the public health position, Paul and Debbie. A question here from, is it Bob Clifford or Clifford Bob? I think it's probably Bob Clifford. Forgive me if I've got it the wrong way around. Would the international community care about Ebola if it were not a threat to the West? Or would it be similar to the relative lack of spending on disease prevention and control for the many chronic diseases that kill far more people in Africa on a daily basis?
Well, the international community is a very, very mixed group of people and institutions. There have always been people in the international community who care about epidemic disease or afflictions of the poor in places far from where they live and work. And so I would say, yes, there would be. The question is really one of scale. And that's why I would just echo what Deb said. We're grateful for a chance to talk to you all because we don't always get that opportunity. And, you know, linking this to Dr. Tolbert's comments about being ahead or being behind, it is his job to be focused on Ebola. But as Deb said, you know, the primary healthcare system in this region has tottered and fallen already. So the shake that has been given by the Ebola crisis has been enough to make it fall. So that means that primary healthcare, malaria, you know, again, complications of pregnancy, we're not ahead. We're way behind. We have to rebuild that, and that's going to require not just a group of people interested in epidemic disease from the international community getting involved, but everyone. And it also is going to, you know, it's going to require a lot of international solidarity from across this continent and across the other ones as well.
Let me ask you about the advice for those countries, this from Rajendra Abhyankar. What is the advice for those countries which have no cases yet, but are vulnerable, not just in Africa, but in Asia, especially countries which have familial and business relationships? Any of you?
Well, we've been very fortunate that both WHO and the Centers for Disease Control in the United States have been working with each of the countries, particularly surrounding the epidemic area, but all countries around the globe have the same updated procedures of how to deal with Ebola patients. I mean, everybody's at risk because people can go over land and people can fly anywhere. So any country has to be ready and understand exactly when that patient comes in, how they're going to be isolated and how all of their contacts are going to be traced and how that patient is going to be cared for. And I think that's what we need to see in every single country. And it's applicable for flu and every other disease.
I would just add to that, since we have here leaders from the political arena and entrepreneurs, that, and again, this is a position I think is buttressed by evidence, historical and current, that travel bans don't work. And there's no reason to believe that they will in this case either. And again, people who are involved in business and commerce know that this is a global economy. And that the idea you can shut yourself off from it by closing borders, again, will be ineffective, but it will be very damaging to efforts to control Ebola in West Africa.
We've got 15 minutes to run. Let me pick up on that point I made right at the beginning while the chairs were being moved about what MSF warned about on the 31st of March this year, of an epidemic of a magnitude never before seen in the distribution of cases. But the next day, the World Health Organization says that the MSF is scaremongering. Quote, "We need to be very careful with an outbreak of sporadic cases." So it comes down to this business of early identification and how that's going to be done. And dare I put it to you, the effectiveness of the World Health Organization. Paul Farmer.
Well, I think we need to have a realistic understanding of what we can ask of organizations and partners. For example, it is easy in retrospect to say that was wrong. After all, it had already become a person-to-person epidemic. There have been those before as well. All of them have been involved, not some eating bushmeat time and time again. This has all been person-to-person admission. Same for Marburg virus, the other hemorrhagic virus that Deb mentioned. But also, even if the World Health Organization in Africa, because it's divided into regions, had said, hey, this is a major problem, we have to sound the alarm bell. Even if that had happened, that would not automatically conjure up out of nowhere the tens of thousands of health personnel we need. Those are going to come from places like rural Liberia, rural Sierra Leone. They're going to be, that the majority will be, even if we get all the doctors and nurses we want and need. Partners in Health has had hundreds sign up for this work.
Because informing that question here from Sharifa Chowdhury, quoting what I said, did the early warning system really fail, or were the signs ignored? Why did this happen? From Blair Glenn Corse, this is a crisis of trust as much as a healthcare crisis. Who has a trusted voice to hold this is very difficult to read, to hold the trust that is needed to fight Ebola, trust and credibility of organizations?
Well, I would just add one thing, and I guess I can look at you all and say, please trust me on this. Because I've been warned by Nick not to use any jargon.
No, I said use it, but explain it.
Okay, well,
we understand.
The reason that the epidemic is out of control is that we have weak health systems. And it's a boring term, and so is its antidote, health system strengthening. I mean,
do you include the World Health Organization in that as part of an early warning system?
Yes. I think the failure is most dramatic, as Raj said, in rural reaches of the world. But even in cities, there are people who don't go, are in the last mile there too. You think about some of these big cities that you all know from around the world, including in Asia and Latin America. There are people living in cities who might as well be living in another century. They also don't have access to social protection and a strong healthcare system because they're poor. And that, happily, has an antidote also, which is investing in them. And of course, we need international, regional early warning systems, but we also have to have a there, as the Americans say. We have to have services available to people based on need and not on their ability to pay for it.
Debbie, what about that leaked email from the WHO saying the writing was there on the wall, but we didn't quite read it correctly?
Well, I think it really gets to complacency. This is probably the 20th Ebola outbreak, maybe the 18th, depending on how you measure it. All of the previous Ebola outbreaks in the last decade have been rapidly diagnosed, rapidly contained, rapidly treated, and again, in the rural areas, because it happened in areas where the health systems had been strengthened. And so there was a there. There were people at the health center when someone got sick, and someone figured out that it was not malaria and that it was Ebola and did the appropriate thing. And in this case, you can see there was a failure in Guinea at the very beginning with the first cases of really seeing that this was Ebola. And we don't really have experience of Ebola getting into cities. Every other time in the last decades, it's been contained in the rural areas. But Ebola is just one indication of all of the diseases that are out there. We don't even know what disease is coming next. These are diseases that are in animals and figure out how to infect humans, figure out how to infect us. And they do it all the time. And this is just HIV, as you mentioned, was one of the largest pandemics. Ebola is another one. We don't even know what the next one is. But together as a global community, we have to have the systems that can detect it.
But will the WHO and the physicians know the next crisis when they see it? Because it would appear to the layperson that actually there was a degree of, as you said, complacency, when there should have been a worst case scenario projection as opposed to an assumption that, well, this is just another outbreak. How do you get over that to prevent this kind of level of concern and exposure of the inadequacy of the healthcare systems?
I believe, and this is why we get optimistic, because we believe we're all the optimistic people. We wouldn't have been in global health for 30 years if we didn't believe in optimism. So out of this, if it comes a call to action on what global health security means and what we all should be doing collectively, this will be an epidemic that, yes, killed many people and was a tragedy, but good things will have come out of it if we act as a global community and we don't sit back again and say, oh, good, we contained Ebola in West Africa, we're all good again. Because the next thing will come, and we'll either be ready or we won't be ready. So these kind of foreign policies that need to be put in place and that integrate relationship with the health systems need to be happening now so that every place has an early warning system. And we can't just depend on WHO. It has to be all of us together.
When you look at it from the grassroots, with the billion who are at risk, including the 60% in Liberia, do you share that optimism?
I do. Despair is not going to solve anything. Despair is not going to solve this epidemic. Only solutions are. And, you know, it's a wonderful foreign policy effort, a wonderful economic effort, a wonderful health effort when you can get behind things that work. And we know a lot of things that work. If we had spent tens of millions of dollars to get community health workers in all the remote villages in Guinea, Sierra Leone, Liberia, we would not be spending the billions of dollars we're spending right now. And we'd save a lot more lives. And we'd employ a lot more people in places where, say, my country, where the unemployment rate, it was 85% in the country. I mean, with employing local health workers, training them, equipping them, building the facilities around them in the furthest reaches of these countries, that 2-year-old boy would not, every time a 2-year-old boy dies of a fever in these countries, in these rainforests, we all should be asking ourselves whether we've done enough. And I think that's going to be the real challenge here for all of us in this room, for those watching, is are we going to go far enough to stop this from coming back again?
So what has to be done? Because there are several questions here, and I hope I'm synthesizing all the remarks that you've put down here on SpotMe. It gets me to a lot of points much quicker about the need for money. There's one question here about a global emergency, health emergency response fund from Clinton Erling, say $20 billion set aside. And one of the questions here says money, money, money. Is that the answer?
Money is part of the answer. It's not sufficient. It needs to be invested in the right way. So we need to make sure, look, Liberia had a weak system. It did not have a non-existent system. I mean, how is it that you have a deputy minister of health on a Skype video call who's got such cogent remarks to make about it? Because he was already there, and he has a plan. He's got a national community health worker plan. He has a national health worker plan for the number of doctors, nurses, and community health workers that are there. The challenge is going to be, are we going to be serious enough about investing in the government plans and the public sector plans and making sure the private sector and the nonprofit sector and the bilateral and the multilateral community rally around them to sustain and execute those plans? It's been done. Deb's done it in parts of East Africa. Paul's done it in Rwanda with the right leadership on the ground. It can be done in Liberia, Guinea, and Sierra Leone. And if we push hard enough, go as far as we possibly can, go the extra mile, as we like to say, it will be done. So a health worker, here's what needs to happen at the end of this. If we're not in this position at the end of this, that we have health care for everyone, no matter where they live. That means a community health worker in every village, a nurse in every clinic, doctors in every hospital, and all the equipment and the training that they need to continue to do their job. This is not rocket science. If we don't get there,
what's the timeline of when that has to be achieved?
Yesterday.
That's why I asked the question.
Yeah.
Is that minister still going to be struggling in a year's time?
He will be if we don't rally behind him, we don't listen to him. But if we listen to him, we'll get there. And again, we don't have to look that far to see what happens. Nigeria, the reason, at least it's reported, is because there were investments made by the Gates Foundation and the Nigerian government and others, I'm sure, in this polio response center that got rapidly converted into an Ebola response center. But it wasn't just the government, it was the Nigerian epidemiologists. It was the local Nigerian health workers that got behind this. And they squashed the disease out, or so it seems there. Why can't that be done in my country? It
All
can
right,
be.
well, that's what Njoya Tikum says. We need to start talking about positive stories coming out of Ebola. Nigeria contained it using money and improved customary practice awareness programs, and says money, money, money may not be the only solution in societies with deep cultural and traditional practices that discourages disclosure. Let me ask you both, Paul and Debbie, about the politics of this then. Raj says yesterday. Well, that's obviously, we've passed yesterday. But how much of it is achievable, and will there be the political will to do it? Is there that political will in the White House?
Well, I think, President Obama just appointed a coordinator to make sure that all of us that are in government are working together to be maximally effective. Because again, part of it's money, but part of it is the person-to-person, people-to-people. It takes people to run programs, and it takes people to talk to people to make things happen. I mean, you see the Liberians have a plan. We need to look at the plan and help them implement the plan. That's what PEPFAR did throughout sub-Saharan Africa, is worked with countries to implement their plan.
Okay, what about Guinea, Sierra Leone, Mali, and where is it going to go next? Will they have the capability?
Well, you should go to the WHO maps because they're really terrific and they're easy to get to. If you just type in WHO Ebola, it will show you where the new infections are. So there are still areas right along the border with Cote d'Ivoire where there's new infections being accounted for in the last 7 days. So this is a concern. We're working very hard with the Ivorians. But you can see this kind of transport that's happening. People want to take care of their families. And they're going to do whatever it takes to help that family member survive. And if that means getting on a bus and going 1,000 kilometers, they'll get on a bus and go 1,000 kilometers. Because people are passionate about saving one another. And we have to put the systems in place to ensure that there's local ability to save one another.
So, Paul, the politics, the budgetary issues, what is achievable? It can't be done yesterday, but the time frame
Well,
again.
I mean, the time frame, again, there's no reason not to be optimistic. And I think when we say money, 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 we should have said finance, 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 because you have to finance education, you have to finance health surveillance systems, you have to finance people. People are passionate about saving each other, and that includes professionals and future professionals. I just want to add one thing from Rwanda, having worked there. It's only 20 years ago, this, past couple of months, that Rwanda was the poorest country on the face of the earth, and where 1 million people had just killed each other. And really, I was already, a medical professional then, and I just remember Rwanda was the latest rebuke to hope in the world. Black hole, never recover. Well, Rwanda is one of the most successful stories in terms of healthcare because it's been a high priority. And the rapidity of turnaround I think should move us when we contemplate
All right,
Ebola.
the last 3 minutes, I don't think the lights are meaning anything. I think someone's leaning against the switch, probably. And you saw this with AIDS and HIV, Debbie, the issue of vaccine and licensing and so on. And we now know the WHO is now testing at least, I think, 3 vaccines, and they say that there could be millions available from early in the new year. Is it too easy to resort to vaccines, or should we see that both as a good reactive response, but also a preventive way forward if it's cost effective? Quickly, all of you.
Well, these are really terrific and hopeful vaccines. shockingly enough, they were developed almost a decade ago, but then Ebola was contained so rapidly that there wasn't any way to test them. And these vaccines are really made to jumpstart the body's ability to make antibody. And so they would be vaccinating communities around new infections. You wouldn't vaccinate the globe for Ebola, but you would vaccinate in the areas of highest threat. And they really jumpstart your immune system to have the response that we think that by giving the plasma, remember how they're giving some of the antibodies back to individuals that got infected, and it looks like they may be important. We don't have the data to say they are, but it's hopeful. That's how these vaccines will work. And so it is exciting to have them as part of our response. They're not a complete solution. They're a part of our prevention response. We still have to be able to identify and care and get the vaccines to the right places.
Paul, you were nodding as well.
I couldn't agree more. Integrate prevention and care. We need a vaccine. We need to take better care of people when vaccines or delivery systems fail them.
And will a vaccine work in that last mile that you are concerned about for those billion people?
If we get the health workers to bring them out there. And you know, illness has been universal. Access to care is not on this planet. And that's what happens when you see a 2-year-old boy in southern Guinea in a village die of an unknown cause of a fever that comes to really affect all of us. And so if we don't get that vaccine that gets developed into the hands of that boy, into the body of those children, and make sure that the rest of the care, because people don't come saying...
And that's achievable among the 60%, is it?
Absolutely. Absolutely. We have no choice but to focus on it in that way, and we've already seen it's been done.
Last quick question, just in all the money that's being pledged on Ebola right across Africa, particularly in the very vulnerable states, is it being used effectively, or is it becoming victim to corruption?
A pledge does not mean a disbursement. and a disbursement does not mean delivery. So the chain is pledge, good, disbursement, very good, delivery, essential to stop this. True of vaccines, true of medications, true of diagnostics, true of therapeutics.
And Debbie, what's your experience on HIV? Does the money get to the people who need it somehow?
Well, the exciting thing about our response, our collective response, was working in partnership with governments to increase accountability and transparency so that every dollar could be mapped to the site where it was delivering services, and we were tracking the results at that site. And now we're making this all public on a website, so civil society, anybody around the world can see what PEPFAR is doing, all the way down to the site level, because that's how you build long-term accountability, is to ensure that the dollars are delivered to the places that need it and have the results that you can measure.
Is that question too cynical, Raj? The question about whether the money will actually benefit the people it's aimed at?
I don't think it's cynical. I think that you know, we know it wasn't reaching, again, that boy in southern Guinea. However, you know, if the question's framed as if it's cynicism about whether it can be done, yeah, then it would be the wrong question, because it can be done, and it's been done, and it's going to be done here.
You know, if HIV is the first example we can find in modern human history of investing across, you know, old colonial relations internationally, if that's the first example, and we think it is, then it shows that it does work. It's a very effective way also of preventing spread.
Okay.
That is.
Thank you very much indeed, Debbie, Paul, and Raj, particularly for the diversions that you've taken to get here, given your commitments on Monday morning teaching back in Cambridge, Massachusetts. Can I thank you all for your messages? I hope you feel that most of what you put on the agenda I've managed to put to the expertise here. You may have entered this feeling slightly apprehensive or deeply apprehensive. I think we've heard in the last 10 or 15 minutes reasons for a degree of optimism, even if the people in my business are obviously focusing on the tragedies, the very human tragedies, in at least 3 countries in Africa, although now 4 with Mali. Thank you very much indeed. I think it's coffee time. Karen.
It is coffee time, but I want to add my thanks to Nick, to Debbie and Paul. Paul and Raj, and also to our two participants who joined us via Skype. I thought it gave a real immediacy to the issue to have Kris Torgeson with Doctors Without Borders and also the Deputy Health Minister from Liberia be part of this conversation. So thanks to them as well. And a special thanks to our fabulous moderator, Nick Gowing. So everybody has earned a cup of coffee or tea, so please join us outside. Thanks.